everyone. Thank you for joining us today. I'm Sharon Anderson, President of Leiomyosarcoma Support and Direct Research, or LMSDR. And I want to introduce my co-host today, Susie Siegel. Okay, Susie, take it away.
Well, we're very honored today to have Dr. Christina Roland from MD Anderson Cancer Center in Houston. She's Section Chief for Sarcoma Oncology, for sarcoma surgery, and Vice Chair for Research in the Department of Surgical Oncology, and Associate Medical Director for the Sarcoma Center. She is also the Executive Director for Surgery for the MD Anderson Cancer Network, and she's known to sarcoma oncologists all over the world.
Well, thanks so much, Susie and Sharon, and it's really my privilege to be here with you all today. I have just a few slides to sort of set the stage of what, you know, I'm sort of thinking of, and then we'll just kind of go through to sort of go through everything. But I definitely want to sort of leave this as a question and answer session. So are you all seeing the slides correctly? Okay, perfect. Yep. I have two screens and I never know which way it's set up, so that's wonderful. Okay. So, you know, today we're really just going to talk about, you know, my thoughts about surgery, and oh, sorry, I just realized that the title of the slide was wrong there, but my thoughts about surgery and how we sort of approach this. But I said I hope this will be a very open discussion. So you all know this, you know, being within the leiomyosarcoma space, but I like to start with this just because I think it's helpful for, you know, setting the stage of what we're dealing with. You know, leiomyosarcoma, although it is a very rare disease, you know, generally occurs throughout, you know, throughout the body like most sarcomas. But really, unlike a lot of other types of sarcoma, is really most common actually in, you know, the GYN space, or about a third of leiomyosarcomas or uterine leiomyosarcomas, or in the retroperitoneum, mainly being vascular leiomyosarcomas, which tend to be arising from the inferior vena cava and that sort of thing. I don't know why that switched back, sorry. And then they can also occur sort of throughout, you know, within any other large vein, like the veins that go to the legs and those kinds of things. But those are really the two most common places, whereas in other types of sarcoma, really in the arms and the legs is the most common. So a little bit different for leiomyosarcomas. So if we just sort of take a step back, I know that I'm the second in sort of a series, and this is actually good. The order I put them in, I think, is actually how you're going to hear about this. You know, when we really think about multimodal treatment of solid tumors, of which leiomyosarcoma sort of falls into this paradigm, you know, there's kind of these three buckets, right? There's chemotherapy under the direction of a medical oncologist, surgery that, you know, usually is a surgical oncologist, and radiation, obviously, with a radiation oncologist. And I've drawn these bubbles sort of the same size, but the role of those really varies depending on the stage of the sarcoma, the leiomyosarcoma, and kind of where we are. So, for example, for patients with localized sarcomas, meaning non-metastatic, you know, surgery is really sort of the central tenet, and something that we always sort of discuss as a way to remove the bulk of the tumor. And we utilize chemotherapy and radiation also to try to reduce the risk of it coming back either in the lungs or locally in the space where the original tumor was. But surgery sort of is the central tenet. Whereas if we talk about you know, for metastatic solid tumors or metastatic leiomyosarcoma, meaning that it has spread sort of outside of the original tumor site, you know, chemotherapy is oftentimes sort of the central and the largest bubble, but we do use surgery and radiation for local control of either metastatic sites or locally recurrent sites or those kinds of things. So this is how I kind of think of how these bubbles shift in size depending on sort of the tumor that we're dealing with. You know, this is the only sciencey part of this talk, but you know, if we think about the way that surgery versus radiation and chemotherapy work, the reason we love surgery so much, right, is because it's what's called zero order kinetics, right? Meaning almost all of the cells are killed with a single treatment, right? You go in there, you take it out, and that's the end of it, right? Whereas things like radiation and chemo, it's called first order kinetics, meaning you kill a proportion of them at a time, but you can never get down to zero, right? So let's say, for example, the chemotherapy kills 50% of the cells. It kills 50% of 100, so it goes to 50, then 25, then 12, and so on and so forth. But that can go on for infinity, right? And so, you know, and if you stop those treatments, then there's also regrowth. And this is why a combination of surgical and non-surgical therapies are really important in order to maximize efficacy and minimize toxicity, because they work in very different ways, right? But as a surgical oncologist, you know, the way that I approach patients when we're discussing incorporating surgery, either for localized disease or for metastatic disease, you know, I talk to patients and I say, okay, what is the goal of the operation, right? And the goal is not, well, we need to remove the tumor. That's the easy short-term goal, right? As a surgeon, I need to either be making you feel better or helping you to live longer, right? One of those two things need to be accomplished with what we're going to be doing, because all of these things result in a change in a patient's quality of life every time you have to undergo a surgery, or really any treatment, but particularly a surgery, because that's what we're talking about today, right? And if we're not accomplishing one of those two goals, we just need to be very clear about why we're going to do the surgery. So the general principles of surgery for leiomyosarcoma, you know, as I showed you, multidisciplinary management is key, right? There's always conversations between myself and the medical oncologist and the radiation oncologist, and whose turn and what order and what thing's going to be the most efficacious with the least toxicity. You know, all of those things go round and round. In the operating room, you know, no tumor rupture is really a central tenet of good oncologic surgery. Generally, we like to do a margin, but in what's called the retroperitoneum, or within the abdomen, where these tumors can be very large and they're touching lots of adjacent organs, margins are usually not possible, right? Because you can't take out all the things that the tumor's touching. And then generally, we aim for a complete resection, meaning we're taking out any of the involved adjacent organs, and we talk through kind of what that actually looks like. So, you know, if we sort of come at it from the other, you know, what am I sort of thinking about when deciding to sort of recommend surgery or not, and having that sort of dialogue with the patient? It's always a balance, and generally none of these things are black and white, right? Most of where we live is in shades of gray, and we have a lot of conversations about, you know, when's the right time and what to do. So first of all is, where is the tumor located? As I mentioned, these leiomyosarcomas, either primary or recurrent, can occur sort of everywhere, right? And so how difficult is it to completely resect? If it's something, you know, on the skin of the arm, that's sort of an outpatient thing that we can do fairly easily, then, you know, we're a little bit more willing to do it in a maybe less than ideal time. If it's a really complicated, large surgery, you know, then we have to talk about some other things. You know, how many additional organs are involved? These sarcomas do not respect, you know, the normal anatomic boundaries that we learn as surgeons, right? And so it's really important for us to think about, you know, not just the short term, you know, can you recover from the operation, but, you know, once you're recovered, what's your life going to look like at the end, right? If we have to take out your bladder and your rectum, and a patient ends up having to have, you know, 2 bags to go, you know, to utilize the restroom, we can talk about that, but we need to make sure we understand what you're going to get out of that, right? Because that's going to be something that's really going to change your quality of life significantly, right? So how complicated is the surgery, and how much is it going to impact your quality of life permanently? You know, is it in a bad location? Is it one of those things where we say, you know, this is really not something that if we took this out, it really would permanently change that? And then the other thing we think about is bad biology, right? You know, although I am a surgeon, I love to operate, I love taking out patients' leiomyosarcomas, but and I hate having the conversation where I say, you know, I don't think surgery is a good idea for you, but the conversation that I almost hate more than that is, we go and we do this really complicated surgery, and we're all really happy at the end because the tumor came out and everything went great. And then 3 months later, the leiomyosarcoma is back, right? And we're sort of back in the same situation we were before the surgery, except now the patient has had to deal with all of the sequelae of the surgery, right? And so one thing that we use to try to, none of us obviously have a crystal ball and can know when that's going to happen. If we would, that would make our jobs a lot easier, right? But, one of the things that we know is sort of, doesn't bode well with doing well sort of after surgery from a sarcoma standpoint is if the tumor's growing really fast at the time that we do the surgery, it generally tends to recur pretty quickly, right? And so that's something that when we say bad biology, how is the tumor behaving? Is it gonna sort of hang on to let us sort of get through this? At MD Anderson, this is sort of our general practice pattern for most patients with leiomyosarcoma. We do a lot of preoperative chemotherapy, even for patients that have localized disease. These tumors can recur in the lungs and in the abdomen. And so we like to try to treat the micrometastatic disease, or the disease that we can't see yet on scans, but we can, we worry is lingering there in the blood or in the local area. And then we often do preoperative radiation with the goal to reduce local recurrence and in the extremity and to aid in a margin negative surgical resection. So those are sort of the things that we generally tend to do. The last thing to sort of talk about that I think is really important to highlight, and particularly for patients with leiomyosarcoma, is I'm sure you all have heard at this point about, sarcoma centers and getting care at multidisciplinary, where they do multidisciplinary care and stuff. But that even extends actually to surgery. And so this is not something that is new to the field of surgery. You'll see here, this is a study from, 2002, where they looked at, the mortality related to surgery for fairly common procedures based on the number of procedures that were done at that hospital, right? And these are for more common cancers, which is, not surprising because these operations are done very frequently. But if you look at something like a pancreas resection, the adjusted mortality, meaning the risk of death related to the operation or the cancer, if the hospital did, 1 to 2 pancreatectomies a year, the risk was 14%. Whereas if the hospital did more than 16, it went down to 4%, right? And so it's not just the surgeon, it's the whole group, it's the whole hospital. And so our group was very interested at looking into this related to sarcoma, because sarcoma is such a rare disease, and we know for common diseases this made sense. And so this is, admittedly, this is not just leiomyosarcomas, but a big proportion of these would be leiomyosarcomas. So what this is sort of showing is two things. So this is using data from the National Cancer Database, which is a large database that captures about 75% of all cancer cases. And so we looked at the number of patients that were having primary retroperitoneal sarcoma resected from 1998 to 2011. And what you could see is that the number of surgeries was sort of slowly increasing over, those 13 or 14 years. But we defined high volume as only 10 cases a year. And this was actually a very small proportion of the hospital. So if you think about that, they're doing less than 1 sarcoma operation a month, right? So that's not, I don't think the bar on that is very high, right? That's pretty low, doing one a month. We do 400 here a year, right? So 1 a month is pretty low. And what you can see is that the proportion of patients having surgery at a high volume hospital was only about 10% of patients, right? So most patients were having their surgery done at a low volume hospital. Why does that matter? Well, what we saw was for either low grade disease or high grade disease, in the red is the patients treated at high volume hospitals. If we looked at their survival, patients that had surgery at a high volume hospital, regardless of their tumor grade, lived significantly longer, up to 10 years, right? And so this was regardless of how old they were, whether or not the size of their tumor, chemotherapy, all of those things sort of even. And the only thing you kind of looked at was where their surgery was done. Patients that were treated at a center that did a lot of sarcoma surgery did a lot better. And furthermore, when we sort of looked at how they did related to their surgery, patients treated at a high volume hospital tended to undergo. So one of the principles of sarcoma surgery we talked about is complete removal of the tumor, right? So if you were treated at a low volume hospital, you were more likely to have an incomplete resection, you were more likely to be readmitted, and actually the risk of death in 30 or 90 days after surgery was significantly higher, right? So again, this is why groups like you are so important to help us advocate for patients being taken care of in centers that have that have expertise in sarcoma surgery. So again, so we talked, that was mainly talking about sort of primary disease. I'm just going to talk for a second about recurrent leiomyosarcoma, and we've done a little bit of work related to this. Again, the principles are still the same. If we're going to talk about doing surgery for recurrence, we need to either be making you feel better or making you live longer. If we don't think we can accomplish either of those two goals, then we need to think about why we're doing it. So this is a study one of my partners did a few years ago, looking at the treatment of recurrent retroperitoneal leiomyosarcoma, and essentially was able to show that for patients that were deemed eligible to have surgery, and so this is where it gets a little tricky, right? Because we evaluate a lot of patients for surgery, but, not everybody is recommended to undergo surgery for a lot of the reasons like I talked about. But those that were able to undergo surgery did do better than those that did not, right? When we look at sort of overall survival. And the main thing that helped us to identify those patients who were going to sort of do better was this variable here called disease-free interval. Patients that recurred sort of more than a year after their initial surgery and had a subsequent surgery did much better than patients who recurred within less than a year. And so we sort of use that cutoff as a time of when we say, okay, if you had your original leiomyosarcoma surgery and then you recurred 6 months later, those patients tended to have a much tougher course and were and it was a lot more challenging to sort of salvage them with surgery than those who say had their original surgery and then developed a recurrence 3 or 4 years later. Those patients tended to do better. So one of the questions I get asked a lot is, why is my, a lot of our patients, as I mentioned, are treated with chemotherapy. And so one of the questions I get asked is, well, why is my surgery so far from my last either chemo or radiation, right? Because we normally wait about 6 weeks after the last chemo in order to do the surgery. And the reason for that is we really just need patients to recover from the chemo, right? Your nutrition generally is not great when you're getting chemo. Your blood counts sort of suffer, and so we need patients strong and their blood really good when it's time for them to have their surgery. And then after radiation, we wait because radiation actually continues to work for several weeks after the radiation finishes, and so we want you to be able to get sort of all your bang for your buck kind of thing. So so in summary, as you all know, and we've sort of talked a little bit about, surgery is really the primary treatment for most localized sarcomas, but the subtype drives treatment and outcomes, and I didn't talk about that much today because we're really focusing on leiomyosarcoma, but surgery is really best performed at a high volume center. We really strive to, and I said we love working with advocacy groups like this in order to help spread the message. And then we use multimodality therapy in order to reduce the risk of recurrence. And then we do selective resection in patients with favorable disease biology, like I mentioned, not getting a lot bigger before we operate on them, a long time from the last recurrence and those kinds of things. And that's sort of how we think about that. So that's all I had from the slides for today, but I was hoping then that we could just open it up for questions and answers to make sure that I was covering the things that you all really wanted to cover today. So thanks very much.
Thank you. That was very comprehensive. I'm wondering if people want to just unmute themselves and ask questions, or you can use the chat box. I don't think, oh, here we go. Will MD Anderson give a second opinion via Zoom?
So it depends on the state that you live in. So and not to get too technical, but and we talk about this now. So during COVID, so I have license in Texas, for example, right? Which means I can practice medicine in the state of Texas. I can't then give a consult to somebody located in Missouri because I would be practicing without a license because I'm not licensed in Missouri, right? And so during COVID, they lifted all of those rules because nobody could travel, right? And so it was a lot easier to do telemedicine at that time. Now that all of those rules have been sort of reinstated, where you can only practice in the state where you have the license, we don't have nationwide licensing in the United States. And so we can only do virtual consults in states where people have a license. So I know that doesn't answer your question exactly, but I would say, Tish, it sort of just depends on where you're located and those kinds of things. But as an institution, we are looking at ways that we can provide sort of better access to virtual visits, because we know sometimes patients can't travel either for financial reasons or for they're in the middle of treatment and it's just not safe to to do those kinds of things. So we are looking to do that more.
Okay, any other
We
questions?
cannot give opinions internationally for sure. We do have an international office that you can reach out to. There's an entire clinic devoted to helping international patients get into MD Anderson. And you can find that on, if you just Google International Center MD Anderson, there's a whole group of people whose whole job is to help figure out how to help get international patients in.
Okay, so California, are you licensed in California? No, okay. How many surgeries in the abdomen are too many?
It's a great question. So there's not a magic number, and admittedly for every patient, it's a little bit different. Every time anybody has a surgery, you form scar tissue, just like you scar on the outside, you scar on the inside. Similarly, people scar differently on the outside. Your scar may look fantastic and somebody else's maybe, you can just tell that they scar a little bit more. The same thing happens on the inside. So, for some patients, 1 or 2 surgeries may be where, that's really the most that they can sort of do because things get too stuck. And for some patients, particularly for other kinds of sarcoma, to be honest, that recur very, very frequently, we have to operate on, again, like liposarcoma, just for example. We have patients that we've had to operate on 6, 7, 8 times, and each time it gets harder, and and that's so there's not like a magic number where it's like if you've had X, then that's too many, but it definitely gets a little bit more challenging with each subsequent operation.
Okay. How often will you combine radiation with surgery?
So for extremity leiomyosarcoma, because I'll just talk a little bit about extremity and abdominal because we treat those a little bit different. So for extremity leiomyosarcoma primary disease, so localized disease, it's your first, it hasn't spread anywhere else and it's your first operation. Radiation plus surgery is actually the standard of care for treating those sarcomas. So every patient with an intermediate or high-grade leiomyosarcoma should get a combination of radiation and surgery for their leiomyosarcoma. In the abdomen, actually, for primary disease, there's a trial that was done recently that showed there's no benefit for doing radiation for primary leiomyosarcoma of the retroperitoneum. So we don't do it for primary disease. The times that we do use radiation is, for example, I have a lot of patients that have, for example, recurrent uterine leiomyosarcoma in their pelvis, where they have a few spots of disease and they've gotten some chemotherapy, and we're talking about doing surgery. In that circumstance, we may do radiation in order to reduce. We know that if I can take out those sites of disease, that's great, but we're worried that there's a lot of other tumors that are sort of there that we just can't see yet, right? Because these tumors often have friends when they recur. And so we will sometimes do radiation to try to reduce the risk that it's going to come back sort of within that area. So in the abdomen now, we really reserve it for recurrences or in places where it's like really bad, where I say, I can take this out, but I never want it to come back. So let's try to do everything we can to maximize the, local control in that area. Oh, Sharon, you're muted if you're talking.
And thank you.
No problem. I was like, oh, her lips are moving, but I don't hear anything.
All right, all right. Is an LMS tumor unique that a high volume center is best to perform surgery, or can you use your local surgeon that is highly recommended?
So, it's easy for me to sit here and say every patient needs to have surgery at a high volume center, right? But I also recognize that, the United States in particular is a huge country. There are not a lot of sarcoma centers, and, recovery after surgery is, can be challenging. The flip of that, I would say, is that the best operation is the first operation, right? So having a good operation at the beginning is probably more important than most of the things that we can do, right? I think there are probably there are a lot of very good surgeons out there, but many of them probably have never treated a sarcoma or only do 1 or 2 a year, right? And we know that that these tumors, it's not just the surgeon, it's the pathologist looking at it. It's the medical oncologist that knows what they're doing. It's the ability to sort of, having good interventional radiology, for example, related to surgery to help manage postoperative complications that happen in these really complicated surgeries, So, at where patients are treated is a very personal decision. But I think that, just being a good surgical oncology is its own discipline because it's not just about, can you cut this tumor out safely? It's what's the biology of the tumor, the oncologic care related to it. Is surgery the best thing to do, up forward? And those things, I can, we all do general surgery to train with. You don't learn those things in general surgery, right? Like those are things that are learned with the additional training that, those of us that do a lot of sarcoma surgery do. So, but I said, I do recognize that, particularly in the United States, traveling to get care is a big, is challenging, right? And I'm not gonna, minimize what that means. But, I said, I think the bottom line is you only get one chance to do the right operation the first time. And there's nothing that I can do later to go back and change that, right? It is what it is, so.
And it sounds like it's the benefit of having the whole team, sarcoma
That's
team with
exactly
you.
right. Yep.
Yeah. I have a question myself.
Sure.
Does LMS require larger margins when you do surgery than other cancers?
So no, actually LMS requires probably less margin. For whatever reason, I didn't show here, but we've learned in the last 10 years or so, we used to just lump things as sarcoma, right? And everything was just sort of a sarcoma. But what we've learned is, just like saying, patients with breast cancer and colon cancer, well, they all have cancer and they do the same. They don't, right? Like those are very different cancers, right? And so leiomyosarcoma, and as I mentioned, liposarcoma, which is another common kind of sarcoma, they're very differently and they behave very differently. Leiomyosarcoma tends to recur most frequently in the lungs or in sort of the peritoneal cavity. The margins that you take generally don't impact that at all. It's related more to have the tumor cells gotten into the blood and what's the biology of that and stuff. So generally, actually, for leiomyosarcomas, the risk of a local recurrence, which is where margins become really important, is actually very, very low. The bigger risk is that it spreads to, I said, the lungs or the, the abdominal cavity and that sort of thing. So
Yeah, we definitely see that.
yeah.
Caroline wants to know, what are the benefits of removing a lung tumor with respect to gaining knowledge of the tumor biology? What are the tools available for analysis?
Sure. So there are, I'll have to add that to my talk. Thank you for pointing that out. So there are, data that for patients that have limited tumors within their lungs that have had some of those features I talked about, right? It's that they've had their disease for sort of a while and it's not growing quickly, that, taking the lung tumors out can be helpful for, for improving survival. We generally, there's a lot of ways that we can now figure out figure out really more about the molecular understandings of the tumor without having to do surgery. So for example, here at MD Anderson, we have an initiative called the Rare Tumor Initiative. It's now called Patient Mosaic, which is exactly sort of what you described. The goal is to really learn, this is more from a research standpoint, but you could apply it similar to clinic, to learn more about the molecular underpinnings of what happens in rare tumors. And sarcoma is obviously one of the more common ones that we do in the Rare Tumor Initiative, because there are so many kinds of sarcoma. And so what we're doing is we're actually, for patients that are undergoing a biopsy in radiology, oftentimes of a lung tumor, we're taking a little piece of that and saving it to do research and all those kinds of things, right? So sometimes we do surgery for lung tumors in order to remove them for treatment. But if we're really trying to understand molecularly what's going on in the tumor, oftentimes doing a biopsy is actually enough of that. And our radiologists are really good about sort of doing enough biopsy where they get enough for the pathologist, but then also enough tissue to sort of do whatever molecular testing needs to be done on that.
Thank you. This one you sort of covered, but I'm interested to see if you have anything to add to it. Under what circumstance would surgery be recommended for a tumor that's already metastasized?
Yeah, so I think, generally speaking, we're always thinking about how can we, sort of help render patients without any evidence of active disease, right? And so and usually that certainly involves the use of chemotherapy to do that. But if there's, a patient that has sort of low volume, sort of a few either lung nodules or, tumors within their abdomen that are, fairly straightforward to resect, meaning that they wouldn't result in sort of long-term, really changing their quality of life. Like I mentioned, like having a huge bowel resection or, things that would really change how they do for the rest of their life. Then we're constantly talking about, does it make sense, to take those tumors out to kind of, obviously we're always hoping for cure, but if cure is not sort of possible, then even to just sort of reset the clock to say, okay, everything that we can see is gone, we can do a chemotherapy break now, and then hope that nothing is gonna, sort of come back after that. So that's sort of how we decide, when to do surgery for metastatic disease.
Okay, great. This question, LMS of the small bowel treated with chemo. If there's a reoccurrence, is surgery an option?
Generally, I would say yes. For the small intestine, there's the small intestine is really important for nutrient absorption. So the colon, for example, patients can have their whole colon removed, and you can live, you can live a mostly, normal life related to that. The small intestine, because that's how nutrient absorption occurs, there's a minimal amount of small intestine that you need in order to be able to absorb nutrients well enough to have nutrition and be able to live, quite honestly. So as long as the tumor, removing the tumor would preserve enough of the bowel that you can continue to absorb enough nutrients, then generally, yes, those can be removed.
Okay, great. Thank you. I don't know if you know what photodynamic therapy is. It's a type of radiation, but in metastatic ULMS, multiple lesions in both lungs, unresectable. What is your opinion of photodynamic treatment?
We're not utilizing photodynamic therapy for metastatic lung metastases for uterine leiomyosarcoma. We do have a couple of things that we'll do stereotactic radiation sometimes for growing lung nodules. Or not in the lungs, but in other sites, we'll do something like cryotherapy, which involves, done by the interventional radiologist, where they'll freeze the tumor, right? So they turn it into a big ice ball, basically, and then the tumor sort of dies that way. But I don't honestly know much about photodynamic therapy for, it's not something that we're doing currently.
Okay, thank you. So Maureen asks, please define what constitutes a high volume center when folks say high volume sarcoma center.
Yeah, I think you know, there's no completely agreed upon definition, but I would say the work that we've done related to surgery has sort of shown that 10 or 12 abdominal sarcoma cases a year is probably the minimum number to be, you know, classified as a high volume surgery center for sarcoma. There's not a defined definition for, well, how many total sarcoma patients do you treat? You know, these are all things that are sort of evolving, but we kind of know from some other work by the group at Georgetown that, you know, once you get to sort of 13 or 14 abdominal sarcoma cases a year, it's pretty much a wash after that. So I would say, you know, now that doesn't count, for example, extremity sarcoma. Those, it's probably a lot higher than that. So we're talking just mainly about that. But I think, you know, to be classified as a high volume center, your surgeon should really be doing more than one sarcoma operation a month. I think that's probably a good, you know, a good guesstimate of how to sort of determine whether or not they, you know, have a lot of experience with sarcoma.
Okay, Caroline wants to know, is a centrally located lung tumor at the base of a lung reachable by for VATS? And I'm not sure if I can read this question right. Is an easy surgery? I don't know how to do thoracic surgery.
Yeah, so I will defer a little bit on that. Generally, centrally located tumors are a little bit more challenging because, you know, they would involve a bigger surgery. Just because centrally is where it's involving more of the lung, and sort of peripherally, it's, you know, if you think about it, kind of like the lungs are like a tree, right? So in the middle is where the trunk is. So if it's involving the trunk, then it's a lot harder to trim the tree than if it's sort of on the edge of the branches, where you can, you know, trim the trees fairly easily, and the tree can sort of survive. So I'm gonna punt a little bit on that one, Caroline. Sorry.
Okay, okay.
Mhm.
With regard to multiple lung LMS tumors, is radiation a better option?
Uh, so, you know, I think for when we think about the treatment of multiple lung tumors in LMS, you know, it's sort of systemic therapy versus a local therapy, right? The radiation is a local therapy, meaning it's only going to kill the things that you target, right? But for example, if you have multiple tumors on the left lung and you radiate those, you haven't done anything about the right lung, right? That one's still at risk of getting the tumors, right? So, you know, it's often a combo, and so radiation and surgery are both local therapies, whereas chemotherapy is sort of a systemic therapy, right? It's killing cells all throughout the body, not just in the area that you're sort of targeting. So, you know, I would say each patient is very different sometimes, and, you know, our groups are very collaborative, where, you know, the radiation oncologist and the thoracic surgeon, for example, will both look at a patient's films and say, okay, for this patient, radiation makes more sense because it's more centrally located, it's smaller, it's going to be harder to find, you know, whatever. There's lots of reasons why they may say that. Or they may say, you know, all of these nodules are sort of located within the same, you know, segment of the lobe. So I could pretty easily take all of that out, and then that would be the end of it. And it's, you know, so it's very patient, each patient is very different on whether one is sort of better than the other, you know.
Okay, okay. I just want to give a reminder to our audience that Dr. Roland can't answer specific medical questions to your case without seeing you, to try to keep your questions general. Okay, and with that, would you recommend surgery for a left para-aortic lymph node met measuring 1.4 by 1.3 centimeters, which has, or would you recommend wait and watch?
You know, again, kind of going back to what you were just saying, you know, it's very dependent on a lot of things, right? We generally like when things haven't changed in 6 months, but it would depend also on sort of how many previous surgeries, you know, what was the original tumor like, what's the risk of developing other sites of disease, and those sorts of things. So, but sometimes for that, we also may recommend, if that's the only site of disease, we sometimes may recommend, like I mentioned, cryotherapy or even radiation as the local therapy. So we talk about all of those things and trying to decide for all of these things.
Okay, I have a question. A lot of times on the support group, we have patients saying they have a few mets and they prefer surgery, but their doctor is pushing chemotherapy. Is it appropriate to get a second opinion with the surgeon?
So I think, these are always really complicated, right? And it's always and that's why I sort of go back to, I kept harping on the goal is to either make you feel better or make you live longer, right? With although we would love, to go in there surgically and remove all these sites of the disease, the truth of the matter is those are probably not the only cells that are lingering around, right? And surgery only addresses the things that we remove, right? It doesn't, if something else is going to pop up in 6 months, it's not because you grew new sarcoma cells, right? It's because the cells were there all along, and for whatever reason, now they've decided to start growing, right? And that's the point of chemotherapy, is to kill not just the things that you can see, but all the other cells that are probably there that just have not grown to the point where we can see them on imaging yet, for whatever reason that we don't understand, right? So, that's why, we often do, multidisciplinary tumor boards where we talk about these things as a group, and we say, does it make sense to come in and do these? I think generally for patients with metastatic disease, as I showed at the beginning, that chemotherapy bubble is really the biggest, because that's sort of the main focus, but we do think about doing other things. I will say, we have a very good relationship with our medical oncologist. Often, I see a lot of patients with a medical oncologist, sort of says, hey, this patient would really like to speak with you. I don't know that surgery is a great idea for them, but they would love to get your thoughts on that. And we're happy to do that, right? Most of the time, I agree, and I don't think that surgery is a good idea, but sometimes we say, what about this? And we come up with some sort of new ideas. So, I think everybody wants to make the patients feel comfortable with the treatment plan. And if you feel like there are things that you're not able to get, I can't give you answers about chemotherapy. I can give you very general things, right? But I don't know what it does, right? I mean, I don't do that. And our medical oncologists are the same, right? They kind of know the things that we tend to want to do surgery for and the things that we don't. But at the end of the day, they will also admit they're not surgeons, right? And so, I think it's reasonable to ask to speak with somebody or have it presented at a tumor board where a surgeon reviews it, or something like that.
Great, thank you. Macy, you want to ask your question? I love hearing your accent.
Hi, I'm sorry, I'm calling from the UK. I was
Great.
actually just really interested to find out what you're most excited about going forward, which has come from any latest research
Yeah,
in
thanks for
surgery.
that. Yeah, thanks for that. So as I mentioned, so we're doing a lot of really interesting work using, as I said, our institution was really supportive of doing a lot of profiling and there was a lot of leiomyosarcoma patients actually, fortunately, in that cohort. One of my partners, Dr. Elise Nassif, has a dedicated interest in leiomyosarcoma and has been working with one of our fellows who's a bioinformatician to sort of categorize leiomyosarcoma's tumors into different immune classes, right? So I'm sure you've all at this point heard about immunotherapy. It's like really exciting for a lot of cancers, but in sarcoma, we've been a little, behind in the ability for patients to benefit from immunotherapy. And so the thing that I'm most excited about is really understanding, and leiomyosarcoma patients have been treated with immunotherapy. They just generally haven't benefited as much as other cancer types. And so I'm really excited about our ability to understand better what's going on within the tumor that they don't respond to immunotherapy, because then we can figure out, okay, if this is the reason they're not responding, then this is what we need to do in order to help them to respond, right? And so that's, I think, one of the things that is really, and I said our group is doing some work on that to try to figure out, because then we can sort of figure out what combinations of therapy we can use in order to make something like immunotherapy work better. So that's the thing that I'm most excited about in leiomyosarcoma.
It sounds exciting. Someone asked, would you expand on the patient mosaic project? Does surgery need to be done at MD Anderson?
Yes. So the tissue, so patient mosaic is essentially, as I said, it's a place that we're capturing either biopsy samples from like interventional radiology or surgical samples that are done, for surgery at MD Anderson. It has to be done at MD Anderson because we need the tissue fresh from either so as soon as they do the biopsy or I take the tumor out, they get a fresh piece of tissue and have to process it kind of immediately in order to save it to do the types of studies that we need to do. So unfortunately, the technology that we're utilizing doesn't really exist on tumors that have been placed in formalin, which is what our normal process is. When you take something out, it goes in formalin, and then that's how you do things later on with it. So it does have to be stuff that's done here. Yeah.
Okay. Okay. I think we have one last question. If post-op reoccurrence was under 12 months, is it typical that it will be the case again for subsequent surgery?
So again, a fairly complicated question. We don't know, none of us have a crystal ball. What we do know is if a tumor is growing such that it recurs sort of within 12 months after, if you had a good operation and the tumor sort of recurs within 12 months, that just tells us that the biology of the tumor is pretty aggressive, and that going in and doing another surgery immediately generally doesn't result in a much longer, disease-free interval, which is what we're looking for. So that's when we will definitely say, okay, let's try something like chemotherapy. If we can sort of get some stabilization of the tumor with chemo and no new things pop up, then again, as I mentioned, it's not because your body grew a new leiomyosarcoma, right? Is that there were little micrometastatic cells that were there that just nobody could see, and for whatever reason, they decided to start growing. And so if you can kind of disrupt that cycle with things like chemotherapy, then we will consider doing another surgery. But I generally don't like reoperating on patients that have recurred within a year, because it's generally just not very sustainable to where they have a long time, after surgery where they don't develop a recurrence.
Okay. And Susie asks, what do you say to people who consider chemo as a last resort? I had a dear friend with leiomyosarcoma who had 7 years of treatment, surgery after surgery after surgery after surgery, and refused chemotherapy. Never had it. Died of a heart attack, but she just would not use chemo. What do you think about that?
Yeah, I would say, the way that we sort of talk about this is the treatment of cancer it's multimodality, right? And what I mean by that is, if we think about it like the military, you can't win a war with just the Navy, right? You need the Army, you need the Navy, you need the Marine, you need all the people, right? Because they all have very different jobs and do very specific things. Surgery only treats the thing that we can see, right? That's the only thing that it does. It can't have any impact whatsoever on any other cells that are around the body. That's what chemotherapy is for, right? Is to kill all the other little microscopic cells that are there. And so, it's a team sport. It's a, whatever metaphor you want to use, but all of the different modalities have a very different role. And generally, certainly, for patients that have not, leiomyosarcoma that has spread elsewhere, surgery alone is rarely the only thing that will work. But we have many patients that have lived, Sharon, as you described, for many, 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 many years. Leiomyosarcoma is so interesting because there are a lot of patients who have lived for decades, honestly, and have had, just sort of do a bunch of different things. I have a patient of mine that I've operated on 3 times now. She's like, oh, I have this lump on my shoulder. Will you come back and take this out? I'm like, okay. And then we do that. And then she goes back on chemo, and then she does a clinical trial. And then she comes back and says, oh, this thing's growing now. Like, okay, let's, and so it's a constant reanalysis of all those things. But you can't win the war with just one branch of the military, right? It takes the whole team. And that's what, that's what we need to sort of do.
Okay, well said, well said. Any other questions? If not, I'm going to close the session. Oh, now you're going to get the thank yous.
My pleasure.
Yeah, we do appreciate your time and effort to educate us and share your knowledge with us. Really, thank you very much, Dr. Roland. We really appreciate you.
It's
we
my
should do
pleasure.
we'll do a virtual clap. Everybody's muted. Yay!
Oh, I
Thank
see
you so much.
somebody I know that just came on.
They just came on.
Oh, well, they just popped up on my screen, so, but
Okay. Yes, this was recorded, so
Great.
I'll have it on the website soon.
great.
Well, thank you, everybody, for coming, and thank you very much, Dr. Roland.